Greetings. Let us learn about acute pancreatitis pathology and how to apply that pathology for bedside assessment and management. I would like to thank my mentor, Dr. Stroline, Mr. Charles Butt for their support, Ms. Angela Deal, my institution, and my mentors. Please take time to read this notice. So here is the pancreas, a gland that is vital for digestion and absorption of carbohydrates, proteins, and fat. It secretes a lot of enzymes, and those enzymes help in our digestion. So you can see the structure of an SNS and where the pancreatic enzymes are synthesized, and they're packaged in zymosin granules, and they're released by the cells. And when you have a pancreas filled with so many enzymes, why does it not undergo autodigestion? So, in order to understand, let us go back to how these enzymes are synthesized and delivered into the duodenum. They are synthesized and delivered as inactive enzyme. In the case of a protein digesting enzyme, the main enzyme, trypsin, it is secreted as trypsinogen by the acinar cells, and as it goes down the acinar cells, down the ducts secrete a lot of bicarbonate to keep the trypsinogen cool down and not get auto-activated. And then they come down the pancreatic duct into the duodenum, where they get activated from trypsinogen to trypsin with the help of an enzyme called enterokinase. So this beautiful mechanism prevents the pancreas to remain healthy and does not get auto-digested. So when this mechanism that is protecting it from auto-digestion gets into trouble, we develop pancreatitis. So let us learn about pancreatitis. Whenever there is any form of injury, either a gallstone blocking the bile duct and the pancreatic duct at the ampulla, or alcohol, or any other type of injury, these injuries cause premature activation of trypsinogen to trypsin. So if there is premature activation of trypsin inside the gland, it does not, it starts digesting it. Otherwise, it starts the process of auto-digestion. It digests the acinus, it digests the ducts, so more enzyme can leak out and more damage. That results in inflammation. So when you have inflammation of the pancreas, you will notice that the patient complains of epigastric pain with radiation to the back lasting for several hours, a deep boring pain with vomitings. The inflammation can also set off systemic inflammatory response syndrome. And how do you identify that? When you go to the bedside, you measure the vitals. Look at the vitals. There may be an increase in the heart rate above 90, a respiratory rate of more than 20, a temperature of more than 38, and elevated white cell count. So these are the things you have to keep in mind and say, hey, what is happening inside the body in this patient with pancreatitis? As the inflammation continues, it leads to fluid extravasation or third space loss of fluid. So third space loss of fluid into the retroperitoneal compartment. You may not see a lot. You may not see a lot of vomitings, but the patient has lost a lot of fluid into the third space. And how do you identify that? You look at the hematocrit. As you lose the fluid and the plasma compartment, the hematocrit increases and it goes above 44, 45. The blood urea nitrogen also increases to above 20. And as you have fluid accumulation in and around the pancreas, you may see fluid around the pancreas on CT scan. And the pancreas tail is close to the left dome of the diaphragm. And then there may be fluid in the left side of the lung or pleural effusion. So these things you can find out on chest x-ray. So with fluid loss, there is volume depletion, and with volume depletion, the cardiac output comes down, tissue perfusion comes down, and with tissue perfusion coming down, there is going to be ischemia and then necrosis. As the necrosis goes on, it can lead to organ failure, cardiovascular failure, respiratory failure, renal failure. So these are all things that can happen step by step. So we have understood the pathophysiology of pancreatitis, at least some of the basics that are easy to remember. Let us recap. Acute pancreatitis. When you see a patient, first thing is you have to see, is there necrosis or no necrosis? When there is no necrosis, it is known as interstitial pancreatitis, characterized by inflammation and some amount of peripancreatic fluid loss. And these patients may or may not have systemic inflammatory response, and they do not have organ failure, they do not have necrosis, and they are likely to recover much faster. On the other hand, if necrosis sets in, you identify that on CAT scan, because on CAT scan with intravenous contrast, you may see areas of pancreas that are not perfused. And when there's no perfusion on the CAT scan, it looks black or dark. And when you have necrosis, you have to anticipate that the patient is going to have severe pancreatitis characterized by systemic inflammatory response syndrome, and patient may develop organ failure, cardiovascular failure with shock, respiratory failure with ARDS, and acute renal failure. I hope this is helpful, and let us put all these things together. When you're looking at a patient, how do you assess the patient? When you have a patient with acute pancreatitis, obviously the patient comes in with a lot of pain, and then you have to ask yourself by looking at their pulse, heart rate, respiratory rate, etc., temperature, whether the patient has systemic inflammatory response syndrome. You also look at the volume status, whether they have a lot of third space fluid loss or not, and you can check it If you have a focus ultrasound, you can look at the IVC and see whether it's been flattened. And you could also check the blood pressure. You can check the hematocrit, whether it is above 45 and a BUN of above 20. So the second thing is you see whether there is hypovolemia or not. Important to correct this hypovolemia promptly so that you can regain the tissue perfusion and hopefully limit the patient from going from mild interstitial pancreatitis to severe necrotizing pancreatitis. So in addition to this, you also want to check, is there organ failure because of hypovolemia and poor tissue perfusion? The kidney can get affected because of systemic inflammatory response and all the uh, chemokines and inflammatory markers that can damage the lung, cause respiratory distress syndrome. So you can figure out what is happening, whether the organ failure is transient or not, depending upon how quickly they recover to your resuscitative efforts. If they recover within 20 to 48 hours, it is transient. If not, you worry that the patient is getting into more trouble. So assessing the cardiovascular status is mostly looking at whether the patient has signs and symptoms of shock, and the respiratory failure, look at the blood gas and see if there is increased gradient, uh, alveolo-arterial oxygen gradient. And for the kidney, you look at the creatinine, whether it's going up or not. On the CT, if you notice that there is pancreatic necrosis, mostly on admission they don't get infected, but they can get infected after a couple of weeks. That is another thing that you need to keep in mind. So we learned that in acute pancreatitis, there is inflammation, third space fluid loss, hypoperfusion, and then necrosis. In the emergency room, and in the first 24 to 48 hours, your management, in addition to pain control, is fluid resuscitation using a balanced crystalloid ringer lactate solution. And how fast do you give and how much do you give? If the patient does not have signs of volume depletion, no hypotension, and on POCUS you see that the IVC is okay, not collapsed, you can give 1.5 mLs per kg per hour. But if you're concerned about volume depletion, then you can give a bolus of 10 ml per kg. And key is to manage the fluids well and not to overload the patient with excess of fluid. That's what we used to do in the past. So this whole thing is based on a recent guideline published by the American College of Gastroenterology on the management of acute pancreatitis 2024. A beautiful resource for you to read. Thank you.